Good morning, everyone. I'm Jacob Buchowski. I'm the chief of the spine division at Washington University School of Medicine in the Department of Orthopedic Surgery. And this morning, we're going to talk about disc herniations, both in the lumbar spine and as well as in the cervical spine. Joining me today is one of my partners, Dr. Deeptee Jain, whom we were lucky enough to recruit from NYU earlier this academic year. We welcome audience participation, so as time goes on, please feel free to ask any questions that you may have. And yeah, we're looking forward to this. Deeptee, I guess I wanted to start this conversation just learning a little bit about what a disc herniation is, what the disc is, how patients develop symptoms, and so forth. Maybe you could get us started with that.
Yeah, thanks for having me, Dr. Buchowski. So disc herniations are very common. The intervertebral disc is exactly that. It's between the vertebra in the spine. And this structure is like the shock absorber in the spine, in the sense that it really carries a lot of the load. Now, over time, this shock absorber can generally wear a little bit. So the intervertebral disc is made up of two main parts. There's a soft jelly-like part in the middle, and then there's a harder ring around that jelly-like part. And so sometimes as we get older, or we maybe sustain a traumatic event, that soft part, that jelly-like part in the middle, can actually herniate or go through that harder, tougher outer band. And that's what's called a disc herniation. Now, disc herniations are very, very common. They're some of the most common problems we treat. And so the next question is, well, how do we know if we have a disc herniation? So disc herniations present in a variety of ways. Some patients have a disc herniation, actually a lot of patients have a disc herniation, and they might not even know it. And that's okay. As I mentioned, it can be part of the normal wear and tear process. But other patients can present with pain. And the pain spectrum can be in a couple of different patterns. So some patients can have disc herniations that present with pain only in the neck or the low back. And other patients can have pain that results from the disc herniation actually pushing on one of the nerves. And again, this can be the nerve in the neck or the low back. And so if the disc herniation is pushing on a nerve, it typically presents as arm pain or as leg pain.
And so I guess the question that I would have, and maybe why don't we start talking about the neck first, since it's higher up. So what are some of the symptoms that patients can have when the disc does push against the nerve?
Mm-hmm. So oftentimes, if the disc is pushing against the nerve, it can cause pain radiating down the arm. And typically this presents in a very specific pattern depending on which nerve is being pinched. And it can start from the neck down to the shoulder and all the way down to the hand. Other patients will have symptoms that can consist of weakness, specifically, again, in a certain distribution. So this may be, and most commonly, can be weakness in pulling the arms or pushing the arms.
And then when, I guess the question then arises, which of those symptoms would necessitate going to a spine specialist? How do you know that you should contact the doctor, and how much time would you give if you were to develop any of these symptoms?
Yeah, so disc herniations in the neck, as I also mentioned, can cause neck pain as well. And it's actually really hard to distinguish between pain that's due to a disc and pain that might be due to other causes in the neck, such as muscle pain or such as ligament pain that's in the neck. And so typically when we think of two broad categories of management, that's non-operative care and operative care, really the neck pain or pain that's localized to the neck is not as reliable to be treated with surgery. That being said, if you are having symptoms either of neck pain or pain radiating down the arms, this can prompt medical attention, and especially if this pain is very bothersome to you. Now, in general, we always try to treat disc herniations without surgery first. And primarily it's because, well, we don't really want to undergo surgery if we can avoid it. So in general, the treatments for disc herniations in terms of non-operative care, there's a wide spectrum of treatments. They start with things like physical therapy. Physical therapy is really important in strengthening the muscles of the neck, and they really stabilize the joints. So we always recommend physical therapy as a first-line treatment. A lot of patients will say that they have some relief by using either heat packs or more commonly ice packs. Those can be relieving. And then other things that we can try include different kinds of injections. So if the disc herniation is indeed pushing on a nerve that's going down the arm, one can consider an injection into the cervical spine. And the goal of that injection is to calm the inflammation that's surrounding the nerve.
Yeah, when I evaluate patients, uh, I I obviously try to treat patients non-operatively. It does always concern me more, though, when patients present with weakness and or numbness in addition to the pain. And I find that I'm much more likely to recommend an operation if someone comes in with a constellation of pain, numbness, and weakness, as opposed to pain alone. Has that been your practice as well?
Yes, absolutely. So, I was really focusing on the pain, but yes, if there is weakness, and if you do indeed have weakness, that is definitely an indication to explore more prompt medical attention. And we tend to be a little bit more aggressive when it comes to treating disc herniations that are associated with weakness and numbness, as you mentioned.
Right. Um, since we're surgeons, why don't we talk a little bit about how you would treat a disc herniation in the cervical spine and how the treatment may differ based on patient age, degree of arthritic changes, and so forth.
Mhm. So the surgical treatments we consider in the context of weakness, as we discussed, but also if the patient is still having persistent pain and symptoms after trying all these other things. And it is, in fact, not uncommon. And in fact, it's one of the most common things that we do surgery for is indeed a disc herniation. So the surgical options are quite a few. The most common surgical options involve going through the front of the neck, and those can involve what's called an anterior cervical discectomy infusion, or ACDF for short, or a disc replacement in the front of the spine. So the decision making between those two is really dependent on the patient. And it's always a discussion between the treating surgeon and the patient about which procedure is best. And here at Washington University, we really like to tailor our treatment algorithms to the patient's various factors, whether that includes age, amount of arthritic changes, and lifestyle. So we tend to treat older patients that especially might have some arthritic changes. Those are more amenable to being treated with an ACDF or a fusion surgery. Now, in our younger patients, we do think about disc replacement surgery. And disc replacement surgery has the added advantage in that it preserves motion in the spine, and it allows for continued motion while still treating the disc herniation. In order to do a disc replacement, we often recommend this surgery in patients who don't have a lot of arthritic changes elsewhere in the spine, because if we were to perform a disc replacement in those patients, they might indeed have persistent pain. So again, it's difficult to say without exactly evaluating the specific patient, but those are things that we think about generally. Another option is what's called a posterior foraminotomy. And again, this is very patient specific, and it depends exactly on where the nerve root is being compressed. But this is a fusionless surgery that again involves just making more space for the nerve. And again, it does depend on where specifically the nerve is being pinched.
Right. Yeah. And this may get a little bit technical, but in my practice, I find that the majority of the time when I have a patient with a disc herniation, particularly if it's at a single level, I end up doing either an ACDF, so either the fusion or a disc replacement. And it's very rare for me to do a posterior-based operation, the foraminotomy that you discussed, because the indications have to be very exact for that procedure to work reliably. I don't know if that's the same kind of practice pattern that you have, but at least that's what I've noticed in my practice.
Yeah, and that's been my experience as well.
Right. And I guess if I think back, over my career, when it pertains to the cervical spine, certainly the artificial disc replacements that we now do in the cervical spine has been a huge change, and really has altered how we approach disc herniations in the cervical spine. Where when I first started, everybody got a fusion, and now, particularly in the younger patients, we're much more apt to do a disc replacement as opposed to a fusion. Very good. I guess why don't we switch topics a little bit and talk about the lower back. Obviously, the low back pain is extremely common. Disc herniations in the lower back are also extremely common. And in my practice, probably the highest number of operations that I do in the lumbar spine, particularly in the younger patient population, is due to disc herniations. I take it lumbar disc herniations, in a way, present in a similar fashion to the cervical disc herniations. Is that right?
Yes, and like your experience, lumbar disc herniations are one of the most common problems that I treat. And again, as we discussed, they do present very similarly, but instead of the neck, we're talking about the low back, and instead of the arms, we're talking about the legs. So very similarly, a lumbar disc herniation can present with back pain, or it can present with leg pain, or pain radiating down, most typically in the region that's down the back of the thigh or the side of the thigh and the buttock and into the foot. This is what we typically, or colloquially, you might hear the word sciatica, and this can present as sciatica.
And how do you approach treatment of disc herniations in the lumbar spine?
Yeah, very similarly to what we discussed in the cervical spine. So again, we discussed pain, but also a disc herniation pinching on a nerve can also cause numbness, weakness. And in those patients, we're a little bit more aggressive in treating those surgically. But typically, similar to the neck, we always try to start with non-operative care if we can. And those things are, again, very similar treatments. The mainstay of treatment is physical therapy. And physical therapy focuses on hamstring stretching, for example, or really maintaining that core strength, and again, building up those muscles to stabilize the spine. And that is a mainstay of treatment. And a lot of patients will get better with that, in fact. Other things to consider are similar to the spine are injections. And the injections serve two purposes. One purpose is indeed, it's a diagnostic test to give us an idea to really say that this is the area that's causing pain. And then secondly, it can make patients feel better, and it might be the only treatment that a patient may need. And then again, very commonly, as in the cervical spine, there will always be patients that have continued persistent pain. And again, that is when we start to think about performing an operation to help improve those symptoms.
Right. I guess one of the other questions that I have for you is, we haven't talked about medications for disc herniations, but often I find that patients who come in with a disc herniation can be in a tremendous amount of pain. What do you do for that? What do you like to do when a patient is in your clinic and they're complaining of significant pain, whether just in the neck or the low back, or whether it's radiating into the arms or legs?
Yeah, again, this is something that we tailor, and it's very specific to the patient, as certain patients have different amounts of tolerances to different kinds of medications. So we often include anti-inflammatory medications like ibuprofen or naproxen. Now, of course, there are some patients that can't tolerate the side effects of those medications, like stomach upset. And so we might consider other medications. There are medications that are more nerve pain related. This would be a medication like gabapentin or Lyrica. Again, there are side effects associated with this, namely sedation. And so some patients don't tolerate that very well. And then finally, we can also consider other anti-inflammatory, stronger anti-inflammatory medication like steroids, or a short course of a steroid dose pack. And so again, the goal of all of these medications is really just to calm down the inflammation in a patient who has an acute exacerbation of their symptoms.
Right. Yeah, those are the go-to medications that I use as well. If a patient presents with an acute exacerbation, often we will use a Medrol dose pack, as you stated, so a 5-day course of steroids. Sometimes we'll use a longer course of steroids, the non-steroidal anti-inflammatories, as you mentioned. and then medications like gabapentin or pregabalin, particularly for those who have had symptoms for a while, can be helpful. I think one of the things that perhaps our audience has noticed is that, we didn't mention narcotics.
Mm-hmm.
And certainly in my practice, the use of narcotics has decreased over time as we've been learning more about the side effects of narcotic pain medications, their addictive nature, and so on. Has that been your experience as well?
Yeah, so I rarely prescribe opioid medication unless someone is immediately postoperatively. And primarily it's because they're not really a long-term solution. As you mentioned, we're learning a lot more about opioids, and it's definitely come to the height of attention that they are very habit-inducing medications that don't really have good long-term potential use. And so for that reason, if someone is really having that much amount of pain for such a long time, I would err on the side of just proceeding with surgery if the pain was really indeed that debilitating.
Right. So before we sort of talk about how patients do after this type of surgery, I guess let me recap a little bit and see if you have any additional comments. But with regards to how we approach disc herniations, whether in the cervical spine or in the lumbar spine, we try to treat non-operatively at first. And I find that majority of patients will get better with non-operative treatment. And this includes things like physical therapy, medications, and injections. And at least in my practice, I would say that somewhere around 75% of patients who present with an acute disc herniation will improve and their symptoms will resolve without surgery. With regards to indications for surgery, when I see a patient with a disc herniation, the things that I look for is patients who have failed to improve with non-operative treatment. So typically we'll try to treat patients non-operatively for at least 6 to 8 weeks, sometimes up to 12 weeks. But if they fail to improve, that would be one indication for surgery. And then the other indications for surgery would be a neurological deficit, so numbness or weakness, particularly if the numbness and weakness is there all the time, and particularly if the numbness or weakness is getting worse. Anything else that I'm forgetting in terms of indications for surgery?
I think you've summarized them pretty well.
I know that when I've had surgeries done, I've always been afraid and a little bit nervous about having things done. How do patients do in your experience when they have, let's say, an artificial disc replacement or a cervical fusion for a disc herniation?
Yeah,
what can
absolutely.
you tell people?
Surgery is scary, definitely. And of course, that there are always things that can go wrong, and we always say that. That being said, nerve pain and pain that's related to pinching of the nerves has a very good track record when it comes to surgery. So I like to tell my patients, and in my experience, that we can expect that in about 90% of patients, they'll have very good relief with their symptoms, both in the cervical spine and in the lumbar spine. And a lot of patients will experience relief immediately after surgery. I'd say about 2/3 of my patients have immediate relief. Then there is a smaller subset, maybe about 1/3 of patients who take a little bit longer to get better. I'd say along, maybe the 4 to 6 week mark, but definitely by 3 months, most patients are pretty happy with their decision to undergo surgery.
Right. Yeah, I find that in my practice. So I tend to ask my patients postoperatively how much better they are than they were prior to the operation. And most of the time I find that patients who have surgery for a cervical disc herniation will tell me that they're about 75, 90, occasionally even 100% better than they were. So I think to echo what you were saying, vast majority of patients tend to do well with these operations. How long do you tell them it's going to take to fully recover? When can patients get back to normal activity?
Yeah, it depends on the surgery. So, in the cervical spine, if we are indeed doing the fusion surgery, we actually have to wait for that fusion to heal. And that fusion is a baby heal by about 6 weeks. It's pretty healed by about 6 months, and then we like to say it's definitely healed if it's going to heal by about a year. So the recovery timeline for having a fusion surgery is a little bit longer than that of having a disc replacement. Now, in a disc replacement, we actually don't need to wait for bone to heal. Really, there is some osseous or bony growth within the implant itself. But overall, that implant is well fixed immediately after surgery. And so those patients, I would say the recovery period in terms of getting back to regular activity is a little bit quicker. We do know, based on our experiences with in contact athletes, that it is indeed safe to return to even high level sports and contact sports after undergoing a 1-level fusion. So patients can get back to their full activity.
Right. I think so patients often ask me, what's going to happen to the adjacent levels, the levels next to where we're doing the operation. Can you comment on that?
Yeah, in the cervical spine, that is a definite concern, especially when we're considering fusion surgery. So whenever we fuse part of the spine, the areas next to it might see some increased stress. So if we are doing a fusion surgery, that is always something that we need to think about. Now, one of the advantages that I mentioned about doing a disc replacement is that it maintains motion at that level. And so the theory behind that is that because the motion is maintained at that level, the areas next to it don't see as much stress, and they don't degenerate as quickly. And that is the real advantage of doing a cervical disc replacement. I think ultimately in the literature, that remains to be seen. In my experience, that has indeed been the case, but disc replacements haven't been quite around for long enough for us to 100% understand that. But that is the theory behind it. And the earlier literature that we had, we have 7 to 10 year outcomes on disc replacement. They do support that.
Right. Yeah, and I think that's at least, if not theoretical, I guess it's mostly theoretical at this point, just because the disc replacements haven't been around for long enough. But that's what makes the disc replacements potentially more appealing than a fusion is that decrease in degeneration at the levels either above or below. Let's talk about recovery after a lumbar disc herniation. When do you, why don't you tell me how patients do in your experience after lumbar discectomy, when you let them return to normal activity? What does the recovery process look like there?
So surgical treatment in the lumbar spine for a lumbar disc herniation typically involves what's called a microdiscectomy. And as a minimally invasive spine surgeon, I like to perform this surgery through a tube. So the advantages of dropping a tube down to the spine is that it's muscle preserving, in that instead of cutting muscle or taking muscle off the spine, we actually split the muscle and use that approach to removing that disc herniation. The discectomy, a microdiscectomy, is a surgery that does not involve a fusion. It simply involves removing the part of the disc that is actually pinching on the nerve root. So because I perform this surgery in a minimally invasive fashion, I have found that my patients actually just don't have very much pain and they recover very quickly from this surgery. So I like to tell my patients that they're up and walking the same day. This is a come and go surgery in the sense that you come to the hospital and you go home later that day. And then in terms of getting back to function, I say I want you to walk as much as possible for the first few weeks. Typically at the 2-week mark, I allow patients to go back to their regular activity. And by that, I mean either a stationary bike or an elliptical or more gentler activities, but cardio activities are okay. And then at 6 weeks, if the patient's doing well, I recommend return to full activity. And then finally, if the patient is playing contact sports, depending on how the patient's doing, I either like to wait to the 6-week mark or more commonly up to the 3-month mark.
Right. Yeah, I guess I'm a little bit more conservative than that, in that I will let patients do whatever they would like, somewhere around 6 months out from surgery, but I do allow them to do low impact aerobic activity soon after surgery, and then gradually increase, with the idea being that they can do whatever they would like somewhere around 6 months out from surgery. As you mentioned, similar to you, I do the surgery under a microscope. It's typically outpatient type of surgery. Occasionally patients stay overnight, but majority of the time they go home the same day. And I find that patients do really well, just as with a cervical disc herniation surgery. Patients who have a lumbar discectomy for a lumbar disc herniation typically will tell me that they're vastly better than they were prior to the operation. Has that been your experience as well?
Yes, very similar. And again, similar to the neck, nerve-related pain is treated very nicely with surgery, and we can expect reliable results with surgery when we think about improvement in pain. So again, my experience has been about 90% of patients will say that they are substantially better than before surgery.
Right. Yeah, I guess since we discussed this in the cervical spine, what are the long-term sequelae of having a lumbar disc herniation or having surgery for a lumbar disc herniation?
Yeah, I think they're really minimal, in fact. Because we're not performing a fusion surgery, we don't need to worry about waiting for that fusion to mature and what can happen to the biomechanics. Doing a microdiscectomy involves shaving away a little bit of bone. It involves taking down some soft tissue that could be pinching on the nerve, and then it does involve just plucking out that disc. Now, one thing that we have to remember is that that disc is not a normal disc, or it wouldn't have herniated. So that disc is never really super healthy. So it is possible that patients can have symptoms or recurrent symptoms later on. It's called a recurrent disc herniation. And that can involve more material that's coming out of that strong outer annulus, more material coming out that can present as pinching on the nerve again. And then ultimately, if that disc is just really not very healthy, they can again have recurrent symptoms, and that can necessitate a surgery in the future. But by and large, the vast majority of patients can expect to do very well with this surgery.
Right. Yeah, I have found that about maybe 5% of my patients who have had a discectomy will at some point come back with another disc herniation at some point in the future. And I have found that some, although it's again a small minority, will come back with more back pain as the disc continues to degenerate. As you said, the discs are not healthy to begin with. They would not have herniated if they were healthy. So sometimes we will see patients come back with more back pain due to those degenerative changes. But for the most part, patients tend to do really well. So I guess the way I would, and at least in my practice, think about surgery for a disc herniation, regardless of whether it's in the cervical spine or in the lumbar spine, is that if it does become necessary, patients do really well. So I suppose one way to think about disc herniations is that majority of the time we can get you better without an operation. But even if surgery is necessary, chances are very high that we can get patients back to essentially near normal function. Is that the way you think about it as well?
Yeah, absolutely. So, we're spine surgeons, we're orthopedic surgeons, and the goal of surgery is to restore function. And so that is our primary objective, is getting our patient back to the things they like to do. And so sometimes these present in younger patients, sometimes it's older patients, but whether it's getting back on that bike or going back to golf, those are the main goals of surgery. And in my experience, patients have been able to return to those activities.
Right. And I guess since we're in the COVID-19 era, question for you, is there anything that a surgical patient should know about surgery during this COVID-19 pandemic? What are some of the steps that we take to help protect our patients?
Mm-hmm. Yeah, this is a challenging time for all of us. And surgery, especially during this time, can be really scary. So some of the things that we do here is that we screen all of our patients before surgery to make sure that they don't have or they don't test COVID positive. This is an effort to protect other patients as well as the staff in our hospital to make sure that we're not giving it to each other and then giving it to our patients. So I think that that's a pretty effective way that we really mitigate the consequences of COVID. Additionally, we're in a separate part of the hospital than COVID positive patients. And so in that regard, we do our very best. Additionally, here in the hospital, we have some universal procedures that really mitigate the concerns of COVID. So for example, we now have a masking policy at our hospital to prevent the spread. And this has been shown in the literature to be actually quite effective in preventing the spread of COVID.
Has the current pandemic affected at all the recovery process and how you approach recovery?
Yeah, I don't think it necessarily impacts timelines for things. I think, we have a now policy in our hospital that currently, and we're not allowing visitors to the hospital. And so that can definitely be a challenge for patients, and surgery is scary. And so that can be a challenge. But nonetheless, we take very good care of our patients, and we keep our patients' family members updated frequently throughout the care process. And so we here prioritize maintaining constant communication, both with the patient and the patient family. And again, this is all in an effort to mitigate the consequences of COVID.
Right. Yeah, I think, certainly what I have seen is that we try very hard to make sure that our patients remain safe during this pandemic, and masking, distancing, and all of those sorts of things have certainly played a big role in that. Anything else that I'm forgetting? Any questions that you may have for me, or any other comments that you want to make to our audience?
Yeah, I mean, like I said, this is a very common problem. We know that low back pain, for example, is the second most common reason that people visit their primary care doctor. But here at Washington University and at Barnes-Jewish, we treat this all the time. It's, like I said, it's one of the most common things that we treat, and we take very good care of our patients here.
I agree. Well, thank you very much for joining me on this. As I mentioned, it was absolutely terrific that we managed to recruit you to join our practice a year ago. And we'd like to thank our audience for participating in this. And if we can be of any help, please reach out. Thank you.